is a reality here, meaning that finding medical care could be tough, particularly for folks who are living in more outlying areas, more rural areas of North Carolina. And it still is an issue. So, to address that need, for several years now, the John Locke Foundation has been advocating for what's called scope of practice reforms. The whole goal is to empower medical professionals with the freedom to practice at the top of their skill level. And we have some barriers in place here in North Carolina. And we're starting to talk very seriously about moving forward to really tear down some of those barriers. In fact, there is legislation now in the General Assembly called the SAVE Act. It was introduced earlier this month. We have one of the co-sponsors with us today. It would give more authority and more autonomy to highly skilled nurses across a variety of disciplines. And we're going to explain what it's all about as we welcome our guests into this conversation. I did mention a co-sponsor is here with us today. She is State Senator Joyce Kravick. She is the Senate Health Chair and a co-sponsor of the SAVE Act. We also are joined by Robert Whitehurst. He is a certified registered nurse anesthetist. He's the president of Advanced Anesthesia Solutions. Dennis Taylor is with us again. Dennis joined us earlier a few months ago for another Shaftesbury panel. Glad to have him back with us. He is president of the North Carolina Nurses Association. And my colleague here at the John Locke Foundation, Jordan Roberts, who is Government Affairs Associate and a healthcare policy expert here at Locke. Everyone, welcome to Shaftesbury Society. So glad to have you all with us. Senator Kravick, let's start with you if we could. What are you hearing not only from your area of the state, you're from Davie and Forsyth counties, that's the area you represent, but from your colleagues as well about what's happening here in our state when it comes to access to highly skilled medical care?
Well, my colleagues and I all recognize that we have a real need to open up some practices to get more providers so that we can increase access to care, we can reduce the cost, and we can take care of the folks that currently don't have a lot of access in many of our areas. The problem is there's always pushback anytime you want to change anything. This is not the first time we've introduced the SAVE Act. But I think that the conditions are better now. A lot of folks have come to the table and they have agreed on a lot of things. And I'm anxious to hear what Dennis has to say also about the nurse practitioners and the CRNAs. And we like to say it's really not a scope of practice. It's not expanding anybody's scope of practice. It's just allowing them to do what they do now, and just making it easier for them to do that. But my colleagues understand that we need to make some changes. I still have quite a few that I have to get on board with the SAVE Act, of course, as always. But I believe we will see some changes this session.
You know, Jordan, I know that you have been writing and researching about healthcare policy reforms for several years here for the Locke Foundation. And the SAVE Act has been something that you have written quite extensively about. Set the table, if you would, Jordan, for the shortages and the need for the SAVE Act.
Yeah, that's right, Donna. So before I joined the government affairs team, I researched and wrote about healthcare policy for the Locke Foundation for a little over 2 years. And, you know, how I would describe Locke's healthcare policy is we look for areas where, you know, particularly the government restrictions and interventions reduce access to care, restrict professionals from practicing, and increase costs. And what you have in the SAVE Act would be amendments to the Nurse Practicing Act that would, you know, greatly increase the ability of nurses to practice. And so what we're talking about here is, you know, particularly with, you know, these advanced practice nurse practitioners, they are often subject to collaborative practice agreements. And what this does is it restricts their ability to practice freely. They must get a supervising physician to, you know, sign off on their ability to practice. And so, you know, especially in a state like North Carolina with so many rural areas, medical deserts, 90 of our counties have primary care shortages, and we know how important primary care is. So, you know, this bill does a lot of good things. And, you know, we believe that, you know, increasing access to primary care, allowing very highly skilled practitioners to practice at the top of their license should just be a no-brainer. We're one of 11 states that still have these very strict supervisory requirements. So, we should join the rest of the states that allow nurses to practice at the top of their license. And before we go on, I just got to give a shout out to my good friend Jordan Jackson. She's in school at East Carolina University to become a CRNA, and she's a consummate professional. And the people of Eastern North Carolina are just going to be so fortunate to have her. So it's folks like that we need to be able to trust and allow them to practice at the top of their license, and that's what this bill does.
So Dennis and Robert, you folks are actually on the ground practicing every day, helping people get the care that they need. Give us a sense what each of you actually does, what your day-to-day work is like, and what's happening in terms of this challenge of allowing people to practice at the highest skill level that they've achieved.
Dennis, you want to start?
Yeah. Go ahead, Robert.
Okay, well, yes, I have been practicing as a CRNA since 2004, and I started Advanced Anesthesia Solutions in 2006, and we take care of outpatient anesthesia needs for facilities and small practices, and we have really seen our clientele grow, our volumes that we're doing grow as more and more procedures come out of the hospital and go into the outpatient setting. So we've been busy as we can be. We practice providing everything from light sedation to general anesthesia. We work in collaboration with physicians, surgeons, dental professionals. We can work in collaboration with podiatrists, providing anesthesia where people need it. And like I said, there's been no underutilization of our services. It just seems like there's more and more care to be provided. And we stay as busy as we can, providing anesthesia, providing it safely. CRNAs, when they're practicing outpatient like we do, we have liability insurance with standard limits. We pre-screen our patients. One of the biggest things you can do when you're out in the community is you can pick your patients well and know where they need to be. Do they need to be in an outpatient facility, or do they need to be in an inpatient facility? And that can really help the outcomes, help you to stay out of trouble as a provider, knowing what patients to use to take care of and what settings to utilize for certain patients. So we've been enjoying providing safe, effective outpatient anesthesia care since 2006. That's who we are.
So you are a CRNA, that stands for Certified Registered Nurse Anesthetist. So based on your description, since I'm not a medical professional, but I've had an outpatient situation where I had to have something done, are you the last person that I see before I fall asleep?
You probably are. So,
right.
In a typical situation, you would see your surgeon, go over your surgery, maybe get marked up for surgery, get your site marked, and then we would come in and see you, kind of do another overview of your pre-op assessment, answer any questions you have, get you to sign an informed consent. When we do our assessment, we'll listen to your heart and lungs, looking at your airway, making sure that everything is where it needs to be, your health history is appropriate for outpatient procedures. And then from there, we'll take you back to the operating room, help you get comfortable as possible in the bed, and then we'll talk you through going off to sleep. And we tell you, we'll see you in just a few minutes on the other side.
Robert, I think that's important for people to understand because we're talking about highly skilled people here. Dennis, when those of us who are not in the medical field use the term nurse, we may have, one conjured up image in our head of what that person does and what that person really doesn't do. But nurses, first of all, it goes across a variety of specialties and really highly educated, highly skilled people.
Yes, and first of all, I want to say thank you to the John Locke Foundation for hosting this and for being a partner with us on the SAVE Act. Nurse practitioners differ from physician assistants in the perspective of we specialize in the patient population. So whether it's adult or pediatrics or neonatal populations or geriatric populations, as well as particular specialties. For example, I am an acute care nurse practitioner. I work in Department of Surgery and Trauma Services at Wake Forest Baptist Health in Winston-Salem. And I work primarily in an inpatient setting, working with trauma patients in the emergency department, in the intensive care unit, and assist with the surgeons, with the trauma surgeons in the operating room. Now, some of my other colleagues may have specialized in primary care, such as family practice, or they may work just with a pediatric population of patients. So, oftentimes, what you find is that those people that are working in different areas have different levels of credentials to take care of those patients, but all advanced practice nurses are educated at least to the master's level, and now many to the doctoral level. I hold two doctorates, a doctorate in nursing practice as well as a PhD. So many of the advanced practice folks, their education is at least beyond high school, at least 6 to 8 to 12 years of additional education in advanced practice nursing. So, the argument that is sometimes used is, well, we just don't feel safe with, some of the other groups and associations want to throw the safety card out there. And the real issue is that there's been absolutely no research that has shown that advanced practice nurses are any less safe than our medical colleagues are, especially in primary care where the real need is. But what we are finding is that people are having a difficult time getting into those areas because of the restrictions that sometimes organized medicine uses. And it really is restrictive trade practice. And that's the part that I think impacts us the most. And that's one of the things that the SAVE Act will help address and regulate. One of the things we know is that almost 80% of the nurse practitioners who go into primary care practice in a rural setting. So that's very different than where you're seeing a lot of the medical professionals move to. It's not as much an issue with a shortage of physicians, it's a maldistribution of them. And, they're up the I-40, I-85 corridors. But when you look in the western parts of the state, in the eastern parts of the state, and some of the more rural areas that we have, we're having a really difficult time being able to recruit any type of healthcare professionals to those areas simply because a lot of people don't want to go there. And we know that nurse practitioners oftentimes are nurses who went back to school through an advanced practice nursing program, and they want to go back to the areas where they grew up and where they're from to be able to practice without having to then go out and secure a physician who does something that's called supervision, that is a very, very loose term, which means every 6 months I get a MD to sign a piece of paper. And that really isn't supervision per se. And the other big issue about safety is, if this were unsafe, why would those other 20 to 30 states who have loosened those restrictions, why have they not gone back to more strict restrictions? They haven't, because they see that it works and it does open up access.
Senator, we talk so much about the rural-urban divide in North Carolina, but it's usually in the context of digital technology, particularly since COVID-19 and issues with access to broadband. But this is really important. I think Dennis's comments about trying to recruit people into some of the outlying areas of the state, was that one of the goals you had in mind when you sat down and said, look, I really need to start bringing people along to understand these impediments that are in place here, impediments that are really keeping people from the care that they need.
Absolutely. We have focused on improving access to health care, particularly in our rural areas, since I've been in the Senate. By the way, Donna, one thing I want to say before I forget, thank you, John Locke, for all that you do. And Jordan, I can't tell you how often I use your research. The first place I go when I have a question is to go to your website, look up whatever it is. Jordan's research has been instrumental in our SAVE Act, in our Certificate of Need Reform Bill. We just rely on the information that you guys put out. So thank you so much for doing that. But yes, we realize that our rural areas, as Dennis said, it's a maldistribution of providers. They are all along in the urban areas, but the rural areas have really suffered. And we think there are a number of things that we can do. The Certificate of Need Reform is one, and another is the SAVE Act. I believe those two things would do more to help our rural areas than anything else we could do at this current time. And I think it's necessary for us to do all we can to get it done. And thank you guys for your support and helping us promote that. And we've got a long way to go, but we're at a great start. And I think we will see some changes in this session. And I'm really looking forward to them. Also, Donna, I wanted to share this. Dennis was talking about the supervision. I met with a group of nurses just not long ago, and one of them told me that her physician, her supervising physician, actually lives in Tennessee, and he flies in every 6 months to sign her paper. And that's not supervision. The whole thing is just ludicrous to me that we call that supervision. So I think we need to expose a lot of what supervision really means, because people just don't understand that that's the level of supervision in many cases that we're seeing.
Well, Senator, thank you for your kind words, by the way. We appreciate that very much. And I agree with you, Jordan is such an incredible resource here for the Locke Foundation. By the way, folks, and you can access all of the research that the Senator is referring to, not only Jordan's work, but across the array of policy issues studied here at the John Locke Foundation. Just go to the website, johnlocke.org, and you'll find it all right there in a searchable format. So this supervisory agreement to me is pretty fascinating, because when we come across things like this in law or policy or regulations, typically it can be traced back to something where the best of motivations and intentions were there when it was imposed, but time goes by and situations change. Jordan, you have studied this a lot. This supervisory agreement, help us understand more about this and what it was all about in the beginning and why now it's time to change.
Yeah, so I think, when we look at when this was implemented, I think medicine was a lot different back then. And, the role of sort of the stereotypical gender in specific professions was a lot different than it is now. And so it's an archaic and old approach to medicine where a physician needs to supervise a nurse. But we know that as medicine has changed and as the needs of Americans and North Carolinians have changed, that we need to update these laws to reflect it. And there is good motivations behind it, that there needs to be collaboration among medical professionals to ensure that the best care is there. But what it ends up doing is holding back a lot of medical professionals, particularly these advanced practice nurses, from practicing at the top of their license and using all of their skills they're trained for. And one thing I would note with this is, if let's say the SAVE Act were to pass and would be signed into law, there's nothing prohibiting advanced practice nurses from entering into collaborative practice agreements with physicians if they wanted to. All this does is pull back those restrictions to allow folks that want to practice independently to do so. And, we've talked about the supply issues, the rural healthcare issues, and especially primary care issues. This bill gets at the heart of that. And, there's been studies done that show that, by 2030, we're going to have a massive shortfall of physicians. And nurse practitioners, talking about the primary care space, that is a growing profession. And so we need to make sure that, the folks that want to practice like this have that ability. When Carolina Journal just did a recent story on the SAVE Act, I got an email from a young lady in Colorado. She's a psychiatry APRN, and she emailed me saying that she wants to move to North Carolina, but she is worried that our backwards laws are going to, restrict what she can do. So she's considering other states to move to. So there's a real world impact, and medicine has changed in this sense that, we have these highly trained professionals, so we shouldn't hold them back. And you can see the real world implications there.
It sounds like such an obvious and necessary step to move forward into 2021, and particularly in a state that is growing so rapidly. But yet, not everyone supports this. Help me understand what the opposition is, and who and why. Why is it that we would want to keep these situations in place? I know that Dennis has mentioned, the safety issue has been brought up, but as Dennis described, the education and skill level required in some of these areas from advanced practice nurses, they have a lot of education, and so one has to wonder what is holding this up.
Well, I would just say that a couple of things. Number one, when just as Jordan said, when you look at the demographics of North Carolina and we see that our overall population is growing and the number of people who are turning 65 is growing every day, we know that the demand on healthcare is only going to continue to increase. So we know that we're moving into a situation over the next 5 to 10 to 15 years where we're going to need many more healthcare providers. As being the person who initiated and started a program when I was in Charlotte at Carolina's Medical Center, there we recruited new graduates in to do a postgraduate fellowship, a 1-year postgraduate fellowship. And it was a great recruiting tool, we thought. A lot of those people would come in, but then they wouldn't stay. They'd come in. North Carolina is known for how good our educational system is in terms of training physicians, nurses, advanced practice nurses, but then getting them to stay is a real issue. And sometimes these regulations is what is leading to them leaving and going to less restrictive states. And it hits right at the pocketbook. You want to know why healthcare costs so much? Well, it's because sometimes these advanced practice nurses are having to pay anywhere from $5,000 to $25,000 a year for this supervision. And that's just to get someone to sign a piece of paper twice a year. So why are people pushing back against it? Well, number one, the most common thing, like I've already said, is they want to throw the safety issue out there. Well, that's just not the case. We know that through numerous studies that have been done. Number two, they say, well, people don't want to use nurse practitioners because they're not as highly educated and trained as physicians are. No, we didn't go to medical school for 4 years. We didn't do a 3 to 6 year residency. However, for the conditions that we are treating, we are most capable of taking care of those patients. Nursing is the most trusted profession and it has been for over 20 years. And now you're telling me you can't trust us to know what our limitations are? Of course you can. We know when we need to refer people out to other specialists. I know that in my own practice in taking care of trauma patients when we need to refer someone to a specialist. So again, I think it is more of a control issue more than it is anything else. And safety is just something that sometimes some of these organizations want to use that to scare people into thinking that it's not the provision of safe care when we know that it really is.
Yes, I'd like to follow up on that too. Yeah, I mean, we see it on the anesthesia side too. We have great schools in North Carolina. We have excellent students, but we lose far too many of those students to going out of state to practice in more progressive practice environments where they can do all the skills they learn. They learn all the regional anesthesia, and they get to go use those skills other places where they're not controlled. So we lose way too much talent. And then, you want to know where it really hits the bottom line is, that talent goes out of state. We're left with a thin labor pool. And then we have hospitals now who are paying way above market rates for anesthesia services. And so, I am acutely aware of that because I compete for anesthesia labor. And it's really hard to get it when hospitals are having to pay way above market rates for anesthesia labor. So yeah, a lot of our talent is going out of state. And I was going to speak too to not to jump into Dennis's area too much, but nurses are so trained to be educators, and so much of the chronic disease we have in our country today, in our state, that cost us so much of our healthcare budget is from lifestyles, lack of knowledge, and the things that nurse practitioners are doing on the front lines to educate patients as they care for them. It's almost inquantifiable how much that is needed. And when you have primary care practices in areas that have months wait to see a primary care provider, or they're not taking any more Medicare or Medicaid patients, it really is the people that suffer. And so, I really tip my hat to the nurse practitioners being out there on the front lines.
So, Robert,
one of the other big issues too, just like has been referred to, we've referenced before, is that we have not had substantial change in the Nurse Practice Act regarding advanced practice nurses in almost 40 years. So we're still under restrictive regulations that were put into place years and years ago. And the educational programs have now transformed into totally different types of programs than we had back then. So now we just need for the legislation to catch up with where the science and the education is for advanced practice nurses.
Robert, you mentioned competing for talent. So how would the SAVE Act, if it's passed and signed into law, how would the SAVE Act affect what you do, your ability to hire and provide out highly skilled, technically skilled people?
Okay, so the SAVE Act would clearly delineate what CRNAs do as a practice of nurse anesthesia. Our detractors have always tried to say that we're practicing medicine, but we're not practicing medicine. When I'm taking care of someone who's having a surgery done and they have high blood pressure incidental to the surgery, I'm not diagnosing them with a disease process known as hypertension and prescribing a treatment plan. I'm treating a condition that it's incidental to the surgery that's happening right there in front of me. It's because of the conditions with that patient at that moment. I'm not practicing medicine. So it clearly defines that we are not practicing medicine. We are practicing nurse anesthesia, what we are trained to do. And as far as making it a more attractive state for CRNAs to work in, everyone wants to be able to do the things that they learned to do. That's why they went to school, to better themselves. CRNAs want to be able to take care of patients from start to finish. They want to be able to use their own skills, their own training to treat the patients the way that they see fit in front of them. They want to be able to do regional anesthesia techniques. They want to be able to take care of patients who are, miles and miles away from any treatment for pain conditions. And with the opioid epidemic we have going in this country, the last thing we need to do is put roadblocks to people being treated for pain conditions. So all of those things really make it more attractive for CRNAs to come here. And I did want to say too that our CRNAs are absolutely excited about this bill. They're excited about our leadership in the legislature, from like Senator Kravick and other legislative leaders who have helped their colleagues to understand what it is we do. And that couldn't be done either without the John Locke Foundation helping us to point out some of the really the silliness of these laws. They're just restrictive. They're not improving care. They're reducing access to care. And Jordan, I always enjoy reading you on certificate of need as well. That's one of my fun topics to beat up on. But yeah, so CRNAs, most all of our CRNAs now are coming out doctorally prepared, and they've got intense anesthesia training, lots of knowledge. They just want to be free to use the training that they're using. And Dennis talks over and over again about the safety aspect of it. I can promise you, as a provider who has a malpractice policy, who likes to continue to practice and provide anesthesia, I'm not in the business of hurting people. That's not productive to me, continuing to do what I love to do. So we as nurses, we have a unique way to care for people, and that does not involve doing things that we feel are dangerous or don't represent patient safety.
And I think one of the other big things too is that the National Governors Association as well as the Federal Trade Commission have both weighed in on this, and both feel very strongly that we should have full practice authority, and that medicine should not continue to have this highly regulated part of legislation in place.
Senator,
yeah,
when you talk with your colleagues, and I know that you're bringing different colleagues on board, is it an issue of legislators just not understanding the situation, maybe what it encompasses when we talk about advanced practice nurses, and that they don't understand that the laws in place haven't been updated in many, many years? Are you finding that once you inform them that they come on board?
In some cases, yes, because we did talk with all of our colleagues to try to get them to come on as co-sponsors. But you still have those who say, oh, no, I've already heard about that at home. I'm hearing from my people at home, which is, they're very loud and they're very powerful in many cases. And so they're just reluctant to sign on because of the opposition that they are hearing from the other side in their own communities. So we are still trying to educate them and to let them know that good policy is good policy, and make your decisions based on good policy, not who approves it and who doesn't approve it. I mean, if that's all we're going to do, we shouldn't be in the legislature. So I differ with some of my colleagues on that. Not that we all don't have to represent our districts. We certainly do. But I think if you go home and you explain to your constituents why you're supporting a certain thing, I don't think anybody's going to oppose this, except for a very, very few that are going to be affected by it. But the general population, most of our constituents, are going to thank us for representing them by doing something that actually will reduce cost of healthcare, improve access, and improve outcomes. No question about it.
As we've been discussing this here, several folks have brought up the issue of aging. And I have to admit that when I have first been studying this, I was thinking this more of a rural-urban situation. But the issue of demographic changes as well, it's dawned on me just listening to this conversation how important that is. As we age, we will have a lot of people who love to come into the very urban areas in North Carolina to retire, because we've got great places in our big and medium-sized cities. So it's really not just an issue about rural North Carolina, it seems to me.
Absolutely. Sorry, Rob, go ahead. Or Dennis, whoever that is.
No, you go ahead and finish your point, please.
I was just going to say that's absolutely accurate. We all know that we consume far more healthcare as we age. And so those people that are coming here to retire are going to require more and more services. So we have to find ways to increase the providers that we have in order to provide that care and attract those people to come to our state.
And I was going to address the aging, Donna, specifically in the anesthesia realm. We have seen this a lot over the past 15 or so years, as the models that our opponents like to use, the anesthesia care team models, where you have 3 or 4 CRNAs being supervised by an anesthesiologist who is, putting out fires, going from room to room, signing charts, seeing patients in the pre-op area. All that's important stuff. But those models are very expensive. And as patients move from private insurance that's paying $50 to $55 a unit for anesthesia care, and they move on to a Medicare role where now the reimbursement is $22 to $23 per unit, those are real world numbers. And those are numbers that health systems can't afford to bear the brunt of anymore. Back in the day when most of your patients were on private insurance, most of them were in the 25 to 60 range, and everybody got good reimbursement, then those models were tenable. Obviously, they lasted a long time, but now we're seeing a lot of chinks in the armor that those models just don't hold up as populations age and reimbursement goes down. So you have hospitals who they nowadays they can't afford to write those checks at the end of the year to cover subsidies to anesthesia groups, because those groups couldn't cover their labor costs because they were heavy on labor. And so, these are real world impacts on small hospitals and health systems. I mean, we have small hospitals all throughout North Carolina that have decided, hey, you know what? I can pay a third provider that's not doing actual anesthesia today, or we can afford to buy a dialysis machine for our community. And so those are real world, examples where things matter.
Jordan, I know that you have done a lot of research and writing on the issue of lowering costs in providing healthcare in general, but I also know in this area that part of the equation here is to not only let highly skilled people practice at their highest skill level, but also to put downward pressure on the costs of health care. And I believe, Jordan, you also referenced in one of your writings about this, about a Duke University study. I think it was health economist Chris Conover who was taking a look at the impacts of this. Jordan, can you speak to the issue of costs?
Yeah, absolutely. So one thing I would start off with, again, kind of talking about how the primary care aspect of this fits into an aging population. I mean, it's just hard to understate how important primary care is, especially with, keeping chronic diseases in check before they become very expensive to treat. And, we all pay through that through our health insurance premiums. So, increasing primary care access, again, with the education aspect of nurse practitioners, educating patients on proper health just to keep them out of the doctor's office. I mean, we want people to be as healthy as they can, to be as prosperous as they can. But, just on going back to Dr. Conover's study, what he looked at was, if we increased the full practice authority for all these advanced practice nurses, potential annual health cost savings could be anywhere from $400 million to $4 billion. And that gets into, these lower cost practitioners providing care, more competition among providers, more jobs in the state, which is more tax dollars, more taxable services. So across the board, there's benefits to this. And again, when we talk about the maldistribution of providers, we have enough providers. We have great providers. It's just getting them to practice in these medical deserts that we know are so rampant in North Carolina. So not only do we have this aspect of the economic and labor freedom of the practitioners, but we also have the effects on the patients too, and cost savings just can't be understated here.
Senator, I would think that the data that Jordan's talking about with cost savings would be a powerful argument as you talk with your colleagues about this.
It is a very powerful argument. It absolutely is. And we must find a way to convince all of them that those cost savings will improve the lives of everybody in our state. But there again, as I said before, there are some who just don't want the pushback that they're going to hear. And nobody likes that. And I would be really interested in Robert's view on this, if I might. I would have to say the biggest opponents that we have apparently are the anesthesiologists. And I would be interested in Robert's comments on that. Most everybody has come to the table, but we haven't been able to get a real discussion going with the anesthesiologist. And I'm very interested in seeing that happen. So I would love Robert's feedback.
Sure, thank you. Yeah, so we've been trying to get our anesthesia colleagues to come to the table and discuss this for many years. And we respect their training, we respect their expertise. There are many environments where a team effort is beneficial to all involved. We prefer to think that happens more in what's called a collaborative practice setting, not an anesthesia care team setting, to where hard numbers are set about how many of each provider you have to have. But I mean, I think we would be remiss without pointing out that our opponents on this issue, they're kind of used to having a 4-to-1 ratio where they get to bill for 4 rooms at one time while they supervise a CRNA. And that's hard. That's kind of hard to let go. If you have a captive audience of 4 people working for you, and you push it as such that everyone has to be in this care team model, there's a huge financial incentive there. And I think there's also a lot of fear there. And I would like to just say that there is plenty of work to go around. No one is going to be putting anybody out of a job. If I was designing my ideal anesthesia group and I was taking care of, mid to larger hospitals, I would certainly have anesthesiologists in my ideal anesthesia group. We can all use our expertise, and we're basically, the standards of care are the same for CRNAs and anesthesiologists. One has a medical training, one has a nursing training. But if you absolutely goof up on a procedure, you're going to be held to the same standard of care. And so there's plenty of work. There's no need to be fighting. We've had other issues in the past that could have brought us together, that we went to them and said, hey, would you come work with us on this issue? And their response is always, unless you drop this supervision issue, we're not going to talk to you. And so, we've not been surprised at the meetings that have been held that, we can find almost every other kind of provider type that's willing to come to the table and have a rational discussion. But when it comes to our opponents, they don't want to have any discussion at all. They want to live like this is like 1950, 1960, and those models still work, and the money's not a factor, and it's just not realistic anymore. It's just not realistic.
Boy, Senator, sounds like you've really got your work cut out for you in that particular specialty area. But I know that the SAVE Act covers a variety of specialties. I think nurse midwives are also a part of this. Am I correct there?
That's correct. That's correct.
Can you talk a little bit about some of the specialties that are covered?
Well, we think, and back to what Robert said, Robert, I've actually had some of my colleagues say, if you will take the anesthesiologists out of it, I will support your bill. So that tells me exactly where the opposition is coming from. Most everybody else has, as Robert said, has come to the table. But we want to improve access to care in all areas. The midwives, and many hospitals now have midwives on staff. And so it's becoming, some people prefer that setting for their deliveries, and hospitals recognize that, and they have brought midwives on staff. So we're looking forward to working with all of the providers to increase access to care for everyone. And I'm hoping that we can get the anesthesiologists to come on board to at least have a discussion. That's my goal, is to try to get them to come to the table, talk to the CRNAs, and see what we can work out. As Robert said, there's plenty of work for everybody. I think there's a lot of, I don't want to say misinformation, but certainly misunderstanding, that I don't think it's going to be the financial impact that they believe it's going to be. As Robert said, the work will be there for all of them. So we're excited about it. We are looking forward to passing that bill, and appreciate any help that the nurse anesthetist and the NCNA Association, and always appreciate John Locke and the work that you do.
We've got a couple of interesting questions coming in on Facebook, so let's turn to them for a moment on this issue of safety, which, it's now coming up here in the comments section of Facebook. Question from Mick. Do NP, that'd be nurse practitioners, have to obtain malpractice insurance? Does removing the supervision requirements cause an increase that makes it hard to afford?
Yes, they absolutely have to have malpractice insurance as a provider of healthcare services. We do. Whether or not that is something that is provided by our employer or whether it is something we go out into the marketplace and purchase ourselves. Um, but the interesting thing is when you look at all these other states who have implemented full practice authority, if the care there was so unsafe, you would have expected malpractice claims to have shot through the roof for advanced practice nurses. That is not the case. So we have not seen in any of the states that have implemented this, those numbers rise any more than they rise with the number of providers that have come into those states. So people say, well, malpractice claims went up. Well, sure they did. That's because there's more providers there now than there were before. But when you look at it as a percentage of people who are providing that care, those numbers didn't go up. So we're not having those issues at all.
We also had a question about telemedicine and how telemedicine and telehealth might fit into this whole equation about shortages of care and the SAVE Act in particular. Who would like to speak to that?
I can. I mean, I'll just start off by saying one of the silver linings of the pandemic was certainly advancing telehealth and incorporating that into the models of care. And so again, I can't harp enough on primary care because I just think it's so important, and telehealth can really bridge a lot of those gaps, especially if we have more nurse practitioners independently practicing, having their own practices in more rural areas. I mean, there's no guarantee that it'll happen, but without passing the SAVE Act, we know it certainly won't. So, it just increases these opportunities. And as we become more comfortable with telehealth and folks get more primary care through telehealth, I mean, this bill will act as a catalyst for that. So I think the two go hand in hand, and especially when you look at what nurse practitioners are going to do in the primary care field if this bill were to be passed.
Also, Donna, one thing, on Thursday of last week at our joint healthcare meeting, we heard from Dr. Saeed, who is a psychiatrist at ECU, and also a group of psychiatrists from Atrium. And we see telepsychiatry. Dr. Saeed has had a plan, and he's looking to expand it, and we hope to be able to help him with that. But many hospitals have no psychiatrists, as you all know, and we end up housing people in the emergency room, which is the most expensive care that you can offer to anyone. And then they're also not getting the treatment that they need while they're housed there. So by using telepsychiatry, they have been diagnosing those patients, transferring them to where they need to go, getting them the level of care that they need, where it may be I had one psychiatric patient in my district a couple of years ago that was he was technically an emergency room patient for 280 days.
Oh, my word.
That is ludicrous. That makes no sense at all. Imagine the cost of that, because we couldn't get him to a bed. So we're looking at using the telemedicine, particularly for a lot of the psychiatry, because we have so many counties that have no psychiatrist at all. And there is a huge shortage of psychiatrists in North Carolina.
And that, again, is one of the specialty areas of nurse practitioners is psych mental health. And there, we have been working with a lot of the educational institutions, both in North Carolina and South Carolina, again, to try to recruit those folks into the state. But again, we hear stories all the time of psych mental health nurse practitioners perhaps practicing in a rural area, and then their collaborating or supervising physician moves out of the area or moves away, and then they immediately have to stop seeing patients. So that group of patients now go completely without any kind of coverage for their psych mental health issues. And that's what's the real tragedy about having some of these regulations in place.
And of course, we're unfortunately hearing about all of the anecdotal stories and research studies now showing that the last year, as we've all been dealing with the COVID-19 virus, as well as the associated gubernatorial lockdowns in many states, like here in North Carolina, that we've got all sorts of people who are having trouble coping. Dennis, are you seeing that in your real world practice, and do you hear that from your colleagues?
Oh, we do. And unfortunately, I think the pandemic has shown the light on a lot of these issues with access to care, as well as, in particular, like you said, psych mental health care. Folks are just not able to cope with a lot of the restrictions that were put into place. Some of them reasonable, others perhaps not so much. And that's the real thing again that we get back. It was like Robert was saying, nurses are born educators, and we really want to be able to get that information out to patients, to be able to educate them on why it's important, for example, to get the vaccine, and then for primary care, especially like Robert mentioned as well. Really preventative health care is the direction we need to be headed in. And being able to have the providers here to provide that information is extremely important. And one of the things you were talking about is, some of the other areas of advanced practice nursing. We've talked about the certified registered nurse anesthetists, the nurse practitioners, and a little bit about the nurse midwives, but there's a whole nother group of advanced practice nurses that are called clinical nurse specialists, who also have very similar training and education that the other three groups do as well. And they typically will work with populations of patients, for example, heart failure patients, and be able to educate them on lifestyle changes, on appropriate medication administration, and really be able to prevent them from then utilizing high cost health care, such as coming into the emergency department or coming in for a hospitalization, when those are things that can be handled more in an outpatient setting. So, clinical nurse specialists are a vital portion to advanced practice nursing, and they're also included in the SAVE Act.
Senator, I would say it's most likely by design that you, as one of the co-sponsors, included this broad swath of medical professionals in this. I mean, this has the potential to have really a serious positive impact here if this is able to be passed and signed into law, not only just for the rural parts, but for the aging population and for that preventive care that will reap the benefits not only for the person, him or herself, but for the state and the cost of providing care down the road.
Absolutely. We realize that it's just not one segment of our healthcare population that needs this expansion, that needs this growth, that needs the opportunity to practice at their fully capable capacities. It's across the board. It is absolutely across the board. These restrictions are limiting our access to care in almost every area. The rural is where we see it the most because some have zero providers. And but even in the urban areas, as I think Robert or Dennis one mentioned earlier, you can't get in to see physicians. I mean, a few years ago, that was never a problem. But now all of a sudden, they're not taking new patients, or you have to book 6 weeks out. So there is a lack of accessible care for almost everyone. And we definitely need to do this. We have to get easier access, better care, and we're going to have better outcomes. If you can get in to see your physician sooner, I mean, obviously, you'll get a diagnosis earlier, you'll get treatment earlier, and you're going to have better health outcomes. So it's just, it's time for us to do this. These antiquated rules and regulations are just holding back our folks from getting good health care in our state.
And in fact, James writes on Facebook, your arguments are strong and this bill should be passed. That from James. So, Senator, what is the prospect? What happens next with the SAVE Act?
Hopefully, my colleagues will all be hearing from their folks at home. They will be calling them to say, you know, this is a good bill. We need you to get behind it, because I can promise you those that oppose it will be out in force. My mailbox has been full since the bill was signed, telling me how unsafe it is and how could I do this and on and on and on. But I am getting some lots of supportive emails as well. So I'm hoping that my colleagues will hear from folks, that we can continue to educate our colleagues to help them understand how this is good policy, and that the arguments that you're hearing are really not valid arguments in most cases. You can break them down, and you can, as the colleagues on this call have done today on this discussion, have all said, it's going to be good for everyone if we can just get it across the finish line. All the naysayers that are talking about the sky is going to fall, as Dennis said, it hasn't happened in the states that have done it. If it had been a bad policy, they would have, you can be sure it would have been repealed already. So the arguments that it's not safe, we've already addressed all of those. Dennis did a great job countering those arguments. We just have to make sure that everybody hears those counter arguments to why this needs to be done.
It is
Donna, can I echo that real quick?
Oh, go ahead, jump in.
Yeah, I was going to say, I for those watching, yes, please be vocal in your support for this act, because your representatives, your senators and representatives, they catch unmitigated heat from the other side for supporting. This is really great legislation. And one way you can know that this is really good legislation is, you know, when the bill came out, we ended up having 77 bill sponsors, co-sponsors in the House to go along with Representatives White and Wheatley and Adcock and Cunningham. And then on the Senate side, we had half the Senate either sponsor or co-sponsor this bill with Senator Bergen, Senator Kravick, and Senator Heiss. So, I mean, it really is good legislation, but the public has to understand that the other side has some of the premier political action committees and ways to put heat on legislators and just make their lives miserable. So, you know, you got to understand your legislators need to hear from you on this, because they need the support. It is really hard to have your phone ring off the hook all day long with people telling you the sky's falling, people are going to die, it's going to be on your plate, this is going to happen on your watch. So they need to hear from the public as well.
Robert, you've been listening in on my phone calls. I can tell.
Senator Kravick, I have heard some of the other sides, and I don't know. I don't want to get into it. I would never speak to an elected representative the way that some of these representatives get spoken to, and the senators. It's just merciless. But you know, when your political action is that strong, I guess you expect a return on your investment, and so you get kind of upset when you don't get the return on your investment that you're looking for.
Jordan?
And I also think when you look at all the other organizations that are supporting this as well, such as AARP of North Carolina, the Americans for Prosperity, the March of Dimes, the Rural Center, Americans for Tax Reform, Concerned Veterans for America, the North Carolina Coalition for Public Health, you know, and there are many, many more. When you look at all these organizations that are supporting this, you know, we're not hearing of other nonpartisan organizations that are opposing this. So I think that's a real telling statistic in and of itself.
Jordan?
Just to put a bow on everything, I mean, we talk so much. Healthcare is an important issue to voters. Access to care is an important issue to voters. And here we have a piece of legislation that addresses a lot of concerns. And I hope that, this 2021 long session will finally be the year that we can grant full practice authority to advanced practice registered nurses and move on to the next healthcare issue.
It is called the SAVE Act. That is what we've been talking about today. Legislation very specific in the North Carolina General Assembly, the North Carolina Senate right now. One of the co-sponsors of the SAVE Act has been one of our guests, Senator Joyce Kravick, representing District 31, Davie and Forsyth counties, has joined us to talk all about this. Senator, thank you. Also, thank you to Robert Whitehurst, who is president of Advanced Anesthesia Solutions. Robert is a certified registered nurse anesthetist. Big thanks as well to Dennis Taylor, who is an acute care nurse practitioner. He is the president of the North Carolina Nurses Association. And of course, to my colleague Jordan Roberts, who has been getting all sorts of kudos here today during this presentation. He is a government affairs associate, and for 2 years, he specialized in healthcare policy here at the John Locke Foundation. Folks, thank you so much. And thank you to you for joining in today to find out more about this. As you can tell from our conversation, every single one of us will be affected by access to healthcare and medical professionals. The SAVE Act is all about that. If you'd like more information, you can find it in the comments section of the John Locke Foundation's Facebook page or on our website at johnlocke.org. I would, before we leave today, just ask you to consider one more thing, and that is to think about the work that we do here at the John Locke Foundation. Our mission is to expand freedom, to defend freedom, to give you more choices, more information, and more options in all areas of your life. That is what we are all about, to give voice to your shared concerns and your shared values. If this is important to you, we certainly hope it is, we would ask you to consider making a financial contribution to the John Locke Foundation. We are a nonprofit 501c3, and we would be most appreciative. It's quick. You just go to johnlocke.org, go to the upper right-hand corner to the Donate tab. Just click on that. Takes you less than 2 minutes to make that secure, tax-deductible financial contribution to help us continue our work here. Thank you very much for considering that. Hope you have a wonderful week and that you come back and join us again next Monday for another edition of Shaftesbury Society. On behalf of the entire John Locke Foundation and Carolina Journal team, I'm Donna Martinez. Have a great week. We'll see you next Monday.